Is that window not?
I can see your disclosures. Yep. Okay. Yep.
It looks good there, Andre.
Yep.
Okay. Well, we'll run with this. So thanks again, Wade and Chasm, for having me present again at this conference, albeit virtually this time. So again, my background's as an emergency physician down here in Vancouver. And I'm also the one of the physicians for the BMX team, as well as the Rocky Mountain EWS team, the professional mountain biking team here. So I have no disclosures, so no actual or potential conflicts of interest. And the title of this talk was given to me by Wade. And so is cycling a contact sport? Definitely we see quite a bit of trauma within cycling, albeit not a whole lot of person-on-person violent trauma, but definitely a lot of injuries, mostly orthopedic within the sport here. So just some videos here. This is one of the many disciplines. So this was from the 2015 Tour of Utah. And while not something that you would expect to see at a bike race, and something that I see quite often in the emergency department, occasionally we do see some cyclist versus vehicle accidents in racing. So this was at Gardens Pass, again, at the 2015 Tour of Utah. And thankfully, the car probably saved this cyclist's life, as there's a cliff on the other side of the hairpin, which he would have probably gone flying down. And fortunately, he only suffered some rib fractures, a pelvic fracture, and a pneumothorax. And this is another one of the disciplines, and this is the team that I look after. So while there hasn't been any racing for us this year, we had a pretty bad season last year with injuries. We've had head injuries, fractures, and in the past we even have athletes with a ruptured spleen who actually suffered that injury twice. And within mountain biking, there's actually a few different disciplines. There's your XC racing, which you see in the Olympics. There's downhill racing, there's enduro racing, and this is a bit more freestyle or free ride riding. And this is a little bit more extreme from the typical racing that we see within the national teams. And that was a video from the Red Bull Rampage. And this is track cycling. And you think, what can possibly go wrong? You only have two riders going around an oval. But these bikes don't have brakes, and the riders don't have the ability to freewheel. So similar to riding a spin bike at your local spin studio, but you don't have the ability to brake by adding resistance. And you can see, depending on what happens and all the other commotion that's going on the middle of the track, you can get some fairly serious or significant injuries as well. So the objectives that I'd like to cover today, so with cycling, is it a contact sport? Definitely we want to be thinking about the various types of traumatic injuries in cycling. I want to talk briefly about a couple cases that surgical management is beneficial. And again, highlighting some of the cases that we've seen within our various disciplines. So this picture here is of the Tour of Poland this year. I don't know if anybody saw some of the highlights earlier on, but this was a sprint finish where one of the cyclists didn't hold his line and took out the other cyclist and sent them flying into the barriers. So trauma in cycling. So all cycling is fairly high risk. Mountain biking, road biking, BMX, they all have very high mechanisms of injury, particularly because of the speed of the sport. So we see injuries from cyclists versus cyclists, cyclists versus cars, and cyclists versus immovable objects. And with cycling, all body systems are at risk. So we hear a lot about concussion, but within the head, we see more serious brain injuries. We've seen athletes with diffuse axonal injury and cerebral edema. We've seen eye injuries, facial injuries, dental fractures. Within the chest, we see lung contusions, pneumothoraces. In the abdomen, we see liver lacerations, splenic lacerations and ruptures, bowel injuries, and from an orthopedic standpoint, just about any possible injury that you can think of. So here's an interesting study. This was done by Haberle, and he looked at the Tour de France over a 8-year period. So from 2010 to 2017. So over that period, there were a total of 259 cyclists that withdrew from this 3-week event. So approximately 17 cyclists per year. And 138 of these withdrawals were due to an acute trauma. And of these trauma, 49% were because of fractures, and 43% of them, or about 29 participants, went on to receive surgery. And of those orthopedic injuries, the most common were of the clavicle, the wrist, and the hand, not surprisingly. So that's a picture of myself. So in regards to head injuries, we hear a lot about concussion, but again, cycling is a very high risk mechanism. So we want to make sure that there's nothing more serious going on. And in terms of head injuries, we like to use the CT head rules to determine whether or not further investigation is required. And this was me about 3 years ago, doing an endo at about 60 or 70 kilometers an hour. And thankfully, I suffered only a mild concussion. So the CT head rules are a set of clinical decision rules that we use to decide whether or not patients need further imaging. So when we pull a cyclist from an event or an athlete and they're in their quiet room undergoing an assessment, we can use these following criteria. So the first part is to assess for any sort of high risk features that would warrant or suggest that this patient may require neurological intervention. So 2 hours after the injury or the incident, we would expect that a patient or an athlete would return to a baseline GCS score of 15. If they're not, that's a high risk feature that warrants further investigation. Any sign of a suspected open or depressed skull fracture, a sign of basal skull fracture, vomiting greater than 2 episodes, and an age over 65 are all high risk features. Other features that are a medium risk for a brain injury on CT would be amnesia before the impact of greater than 30 minutes. So it's quite normal to have some amnesia surrounding the impact or the incident, but any retrograde amnesia greater than 30 minutes is a high risk feature or a medium risk feature. And also a dangerous mechanism. And I'd throw most cycling injuries or incidents as a fairly high risk mechanism. So some other specific cases that we've seen in our practice. For this one here, this was one of our riders, and they suffered an orbital blowout fracture. So in addition to a concussion and some severe facial injuries, they suffered an injury to their eye. So an orbital blowout fracture occurs when there's a fracture to any wall of the orbit. Most commonly, This occurs to the medial wall or the floor of the orbit. And this is either caused by a direct blow to the eye itself or the globe or the orbital rim. And some of the features to look for on physical exam are enophthalmosis, which is a sunken eye, abnormalities with extraocular movements. So these patients sometimes have difficulty elevating their eye or looking up due to entrapment of one of the extraocular muscles. They can get diplopia, again, due to maltracking, and they can get numbness to the cheek area underneath the eye. And that's due to a fracture that affects the foramen for the infraorbital nerve. And some of these athletes or patients will report they'll get some swelling or some pressure underneath the eye after blowing their nose. And that's because the fracture is extended into their maxillary sinus. So again, just a picture describing the mechanism of injury. So the blow or force is either transmitted either directly to the orbital rim with the weaker medial wall getting affected, or when you get a blow directly to the globe, that causes an increase in pressure within the orbit, and that disrupts the orbital floor. So the best test to assess for this injury is a CT scan involving the facial bones. But often if you're in a clinic with just access to X-ray, plain films can sometimes be suggestive of an orbital blowout fracture by looking for a pacification of the maxillary sinus. And that's a sign, again, that there's blood where it's not supposed to be. And our athlete ended up requiring surgery. And indications for surgery include a sunken eye, extraocular muscle entrapment, and diplopia. So the next injury is probably one of the most common injuries in cycling. And in fact, it was the most common fracture in the Haberle study. And that's fractures involving the collarbone or the clavicle. And most fractures occur to the middle third of this bone. And historically, these were managed with a sling immobilization and a gradual progression to gentle range of motion after about 2 to 4 weeks, and then some strengthening at 10 to 12 weeks. So as you can see, it's a fairly lengthy and delayed process, not ideal for a high performance athlete. Clinically, historically, the indications for surgery were open fractures or skin tenting, neurovascular compromise, severe displacement, and shortening of both ends of the fracture fragment of greater than 2 centimeters. And this is typically how these fractures heal. So oftentimes you'll see a deformity over that patient's clavicle, but generally this does not affect the patient's function of their upper extremity. And despite seeing x-rays where both ends of the bone are quite a fair distance apart, there's actually a very low rate of union or non-union in these types of injuries, generally about 1 to 4.5%. So a real life example of a clavicle fracture was Lance Armstrong. And this was during his return to cycling coming out of retirement. And he suffered a fracture of his clavicle on March 23rd, 2009. And 2 days later, he returned home and received surgery. And within about 5 weeks, so April 29th, he had full recovery and returned to racing at the Tour de Gila. So this is a real life example of how quickly some of these athletes can return with surgical fixation. So quite a deal quicker or shorter recovery than your traditional conservative management. And because of the timing of the injury, so that spanned April Fools or April 1st, one of his sponsors decided to put up an ad for a carbon fiber plate. But as far as I'm aware, These are still made of metal these days. So those that, in regards to surgical repair of the clavicle fractures, those that had surgery returned to competition in about 5 weeks or 37.6 days versus the 75.5 days of those that received conservative management. And this was statistically significant. So again, quite a shorter time frame for recovery. And early repair of the clavicle allows for early range of motion and load bearing. And the most common complications include numbness at the site just below the incision, infection, and non-union. So here are some pictures or some examples of athletes that are returning to training after their surgery. And usually when their pain subsides, they're able to get back onto a bike. And you can see a couple various contraptions. So this gentleman on the left has a harness to help unload his upper body. And this other gentleman on the right is riding with a sling. And I've seen pictures online of one of our athletes, Mike Woods, who has ridden with a stability ball on handlebars, again, doubling with a bit of core and stability work, but also raising the bars and unweighting the upper extremity. So for athletes or high performance athletes, they can get back on the bike within a few days with minimal loss to fitness. So another common fracture are scaphoid fractures. And the most common mechanism of this type of injury is a fouche, which stands for fall to outstretched hand. And we had a racer with this injury who made a diagnosis over Skype and via photos from halfway across the world after a race. And your clinical findings include pain over the anatomical snuff box, pain over the tuberosity on the volar aspect, and pain with axial loading of the thumb. So with scaphoid fractures, oftentimes plain radiographs may be normal. And if you have a high suspicion for a scaphoid fracture, so clinically they're quite tender and you have a good mechanism of injury, the standard of care is to immobilize these patients, usually in a thumb spica or radial gutter, and to repeat imaging in 10 days. If you have access to CT or MRI, these may be useful in expediting a diagnosis. And the reason why these are important is because of the blood flow that goes to the scaphoid. So fractures to the distal pole can disrupt blood flow because of this retrograde circulation. And if these injuries are not detected, they have a high risk or a rate of non-union, and these patients may develop AVN in their wrist. So our athlete ended up getting a screw fixation, and surgical management for these fractures often, again, allows for early return and avoids complications with prolonged immobilization. So as with a lot of sports medicine, we hate to immobilize things for prolonged periods of time as it results in a lot of stiffness and decreased range of motion. And with surgical fixation, that prolonged period of immobilization is not required. And athletes may begin early non-contact or low impact activities. So our athlete, after getting the screw, was riding on the trainer within a few days, and within a week or two was back to riding a bike outdoors. And 4 weeks later, he started taking jumps on a BMX track. So not totally low impact, but you know, with caution and low risk for crashing. And within 5 weeks, he returned to the Canadian Championships, which he eventually won. So also looking at risks here, or wrists. So this is another mountain biking injury which I've seen, and a third friend of mine who's wrecked himself on this exact same trail. So in addition to the scaphoid injury, which you can see here on the left x-ray, this patient also suffered a perilunate dislocation. So always make sure you're looking at the lateral x-ray. And if you look at the AP view, you can see Gila's arcs. They don't quite line up. And if you look on the lateral, you can see the empty lunate. So that's a sign that there has been a dislocation or a perilunate dislocation. And the other common fracture site, again, of the hand, this was one of our EWS mountain biking athletes. Again, while overseas, he suffered a fracture to his metacarpal, his proximal phalanx, and had a dislocation of his PIP joint. And while undergoing treatment overseas, because of anti-doping, he was afraid to get any local anesthetic, and they were unable to reduce that finger. So he flew back to Vancouver, where he was subsequently relocated. So one of the anesthetic methods that would have worked well for this athlete would have been an ulnar nerve block, and that would have managed the pain of the fracture and would have probably allowed for an easy reduction. So hand fractures are managed pretty similarly across most athletes. And most fractures can be treated with a splint for approximately 2 to 3 weeks once the bones become sticky. And this allows for, again, early range of motion, as the most common complication to hand fractures is stiffness. Displaced fractures, displaced proximal base, the metacarpal fractures, and unstable fractures may require surgery. And return to activity is often possible with a custom-made splint fabricated by some occupational therapists. And here's a picture showing some of the modifications that allowed our athlete to return to racing. Because he wasn't fully able to make a fist, extra padding was added to the end of his bar end to give a little bit of extra diameter, and his glove was cut at the fingers to allow for some buddy taping and splinting, which provided him some extra comfort. And he went on to race with a digital block in the finger and was able to complete a run just after a couple weeks from the top of Whistler Mountain all the way down to the village. So approximately a 20-minute stage that's clearly quite rough and demanding. Okay, and so I just wanted to finish off with a video, and this time with some successful tricks and no crashes and no injuries. All right, so thanks, and any questions?
So if anyone has any questions, just please feel free to enter them in the Q&A section. Okay, so the first question, Andre, it comes from Anita. What are some of your challenges getting the athlete off the bike course with serious potential for head injury and neck injuries?
So Thankfully, most of these events have pretty good on-site medical coverage, but the helmet often is an area that can get in the way. And with getting these athletes off, it's important to just maintain proper inline stabilization. I would say get the helmet off, and then get the athlete rolled and boarded and collared.
Next question, which isn't really a question from Bruce, is thanks, Andre. That was a very good talk. Next question. Sadly, I've heard similar stories where injured athletes do not receive appropriate anesthesia or pain management for fear of AD transgressions. AD should be about health. Doctors need to know the rules.
Yeah, Alan, that's a good comment. And so again, it should be about the pain management and health of the athlete. And athletes can always apply for a TUE, or their team physicians can submit a TUE after the fact. So they shouldn't be concerned about receiving analgesia for the management of their injuries.
Next question is, why would your cyclist not get adequate freezing for reduction?
Again, that's going back. The cyclist again was not aware of the anti-doping rules, and I often even find it difficult to get my athletes to take Tylenol and Advil for fear of anti-doping.
Okay, next question, Andre. For head injuries, if all athletes are immediately medium risk based on a dangerous mechanism, assuming the Canadian CT head rules are negative otherwise, do you use anything else to triage, i.e. watch for a couple of hours, etc.?
Yeah, I definitely would recommend watching the athlete for a couple hours. The high risk features, again, indicate GCS of 15 at about 2 hours. And I believe our Cycling Canada protocol indicates that we should not be leaving our athletes alone for any prolonged period of time, and observation for probably the rest of the day.
Okay, no further questions. Thanks, Andre, for that talk, and great videos to go along with that, and excellent management discussion.
Thanks, Wade.
Okay, so our next talk is, our speaker is Dr. Scott Shallow. Scott is a former PGY3 resident at McMaster. He's now working in Kingston currently. I've asked him to speak on the topic of the tired athlete. So our topic presentation title is called Overtraining the Tired Cyclist. Why is my rider getting dropped? This is a pretty common complaint that we see, that I see anyways, with the athletes that I work with. And I think it's worthwhile delving into how to manage these patients. So we'll let Scott go ahead.
All right. Well, thank you, Wade, and thanks for everyone who wanted to join in. It's nice to see that we're able to get something going despite the new world we live in today. I can see Andre still. Can you give me a thumbs up to let me know that the screen looks good and you can hear me? Awesome. Beautiful. All right, here we go. So why is my cyclist getting dropped in the approach to the tired cyclist? So I have no disclosures, so nothing to talk about there. And so first, I'm just going to touch a little bit on a case that we dealt with when I was a fellow with Wade, part of the Team Canada medical staff for the 2018 World Cup that was hosted in Canada. So we had lots of interesting things come up that year. So in terms of the case, we'll touch on kind of throughout the talk. We have a 21-year-old male cyclist for the Canadian national team, presented with a 6-week history of extreme fatigue, very explicitly occurring halfway through or 3/4 of the way through his efforts, to the point he has to stop halfway to 3/4 of the way through his efforts. He just has nothing left in the tank. His legs feel fine, no injury concerns, nothing really to complain about there, no chest pain, no shortness of breath. Query, elevated heart rate on his heart rate tracking that we were doing at the time, but it wasn't really that impressive, but it may be a little bit of a bump. and definitely a slow recovery between efforts, which is obviously very important for these guys as they're doing dozens and dozens of efforts in, within a single training session. Physical exam, head to toe, completely normal. Only thing I was passed about the history that's of note, interestingly, is he actually is the only person on the team who had chronically low ferritin to the point that they were followed by heme at one point. Only medication was an iron supplement. World Championships were upcoming. They were in the next couple of months, so pressure was on a little bit. And so last year, this was a little bit easier. We kind of threw out the idea of what more did we want to know. Obviously, there's a lot of different things we could talk about in terms of what we need to know further on history. So we had a bit of a brainstorming, but truthfully, the answer is basically everything. There's a lot more we need to know about what's going on. So to cover a bit more of that, we'll just throw it at you. So what more do we want to know? There was a recent switch from the outdoor to the indoor season. So this is a massive difference in terms of training protocols for these Canada cyclists, where they're going from incredibly long distances to very short, powerful bursts in the indoor track that, are completely different events they're training for. No recent illness, no sick contacts or anything like that. And luckily it was in 2018, so no concern of COVID. Continue to take his iron because obviously we know that young athletes aren't the best at taking their medications, especially on time. No change in diet, not like he switched to being vegan or vegetarian without anyone letting anyone know or consulting the dietitian. No major emotional stressors in terms of, parent divorce, no breakup with a, partner or anything like that. No major disruptions within the team that were affecting him. So obviously, we talk a little bit about the differential, where we want to go with approach investigations, and then what do we tell the athletes and the coaches, right? So these are kind of the things that'll be ruminating through the top of your brain and where to go next. So a lot to deal with, especially with that time crunch of the World Championships upcoming. And that was also the year we were hosting them in Canada at the Velodrome in Milton. So there's a little bit of an extra kind of push to want to compete and want to be there, as well as perform well. So I just threw this up there just so we can a little bit of an idea of how incredibly big of a differential we have when the approach to the tired athlete or the tired cyclist comes up. We're basically considering every single, physiological system. So from a hematological standpoint, we're obviously going to see a ton of the anemia and a ton of low ferritins, like we do in a lot of our endurance athletes. The psych component, which Dr. Edwards is going to talk a little bit about later, obviously a major component here, specifically in these sort of endurance athletes. A lot of them away from home, a lot of them are younger, early 20s, late teens. So disordered eating, big things to consider. At the time, not something we consider, like I mentioned, but COVID, huge implications moving forward, and things that we're going to kind of have to, again, reassess how it's going to affect our team athletes moving forward. RED syndrome, relative energy deficiency syndrome in sport. So massive topic, obviously worth a whole lecture of its own, something to consider. The cardiovascular stuff, the cardiomyopathy is always important, especially when we're getting an athlete with declining performance. Dietary changes, major implication in terms of power athletes as well as endurance athletes. And then the other stuff that we can all think about, sort of substance abuse, whether it be prescription, non-prescription medications, sleep disorders. And then last, lo and behold, overtraining syndrome, almost like I stuck that in there at the end for the purpose of the talk. So more about the patient. Labs, largely completely normal, to be honest. Hemoglobin, all the scary stuff, completely normal. ECG was normal, thyroid was normal. Interestingly enough, we had a very bad case of a thyroid condition in an athlete that same year, but wasn't him. Ferritin, chronically known to be low at 18, and that was actually about where he normally stood, and even sometimes a little bit lower despite high dose iron. Completely okay with heme, and we also ran this by them, and they had no concerns because there was no change. So the diagnosis ended up becoming overtraining syndrome. So obviously we're going to talk a lot about overtraining syndrome today, and I'll try to touch on some of the key points, but sort of just initially to talk about what overtraining syndrome is and how to differentiate it between overreaching, which is really one of the cruxes of physiological adaptation to sport. So the idea of overreaching is when you accumulate a training volume, including non-training stressors, relationships, psychological things, leads to a short-term decrease in performance capacity. So now that comes down into how they recover from that training or that accumulation of training capacity, and that returns in their performance within kind of the days to weeks. So you can imagine it's like if you train your bicep incredibly hard, as many of the people listening today probably are aware that I like to do quite a bit of that. Lots and lots of training to that bicep, you're going to have a reduced strength capacity and performance capacity, recover in days to weeks, and boom, that's the crux of adaptation to sort of muscle training and sport. What we're going to differentiate here is the difference between functional and non-functional overreaching. So functional overreaching is you accumulated training, insult to the body, you allow for appropriate rest, and then functional recovery means you've then gained a performance capacity increase, and you're therefore increasing your performance. Versus non-functional overreaching is you're not matching the amount of rest necessary to recover from that increased training load or insult to the muscles in the body. Then we slip into the idea of overtraining. So even as of last year, when I gave this talk, the kind of general gestalt was that it was a diagnosis of exclusion, which we'll talk quite a bit about how that has changed in just in the last year and a half. So previously it was a diagnosis of exclusion, something that you considered in certain athletes. But basically it's the accumulation of training plus non-training stresses, which is leading to long-term decreases in performance capacity, where the restoration of performance takes several weeks to months, and even cases have been documented up to taking years to recover from that. We'll talk a lot about this today. It is important to know that the idea of functional overreaching, non-functional overreaching, and overtraining all exist on a continuum. And many athletes can be on that continuum for years, some can go into and out of it quickly. So it's really important to kind of consider all of that, and that sort of continuum does make it hard to really identify when athletes are slipping into, functional versus non-functional overtraining. So that's why obviously monitoring becomes very important, and the idea of prevention in these cases, which we'll talk about very shortly. So the big difference with the functional overreaching, non-functional overreaching, and overtraining syndrome that we need to kind of bang into our heads is really the outcome in terms of performance and how much of a performance decrement we're getting. The functional overreaching, days to weeks, right? So this is your training camps at altitude where you're not going to be able to race right after it, but you're working really, really hard for those 9 days. But then 2 weeks later, your performance is better because you have adaptations. Non-functional overreaching is you're looking for recovery from weeks to months in your performance. And then, like I said, overtraining is the months to even sometimes years. So very important to consider and keep on sort of the back of your mind. So frequency of overtraining. Very difficult to measure due to the multiple facets of it. And it's an incredibly complex condition. The believed epidemiology is approximately 10% in elite athletes. Again, this is a huge variation. Is this our wrestlers? Is this our cyclists? Is this our runners? Most of the data at that time, when I had this from last year, was 10% came mostly from cyclists and rowers, because that seems to be the biggest area of interest in terms of research. There was one study that showed university athletes, predominantly females, where 60% of elite runners reported at least one episode of fitting the criteria for overtraining syndrome throughout their career. 33% in non-elite runners, and then again, 35% in young elite swimmers. So, but most of this was retrospective data in terms of monitoring for those populations in terms of prevalence. Huge risk of relapse, like there is in many of these people and patients, because they're going to go back to their sport, and we know that they are. Endurance athletes love what they do, and especially, the highly competitive ones are going to go back, and part of the problem is making sure they don't go back too soon. And again, I can't stress enough the poor epidemiological data thus far about it. Hopefully with the kind of changes to the diagnostic criteria and things like the updates in the last year, which we'll talk about near the end of the talk, hopefully that'll keep coming out in the fray, and we'll get a little bit better of an idea moving forward. So this is just thrown in here just to give us an idea of some of the confusing aspects of the pathophysiology. And again, so this is sort of pre-2019, pre-2018 proposed pathophysiology. So there was the cytokine hypothesis, believing massive increases in inflammatory markers cause cell destruction, as well as a decreased functional oxygen carrying capacity of the blood, etc. There was the hypothalamic HPA type proposed mechanism, leading to a massive decrease in functional adaptation. There was also the glycogen hypothesis. In a nutshell, low glycogen storage led to combination of muscle fatigue and mental fatigue. And then there was also the BCAA, or protein deficiency hypothesis, same type of things. So this is sort of really, no paper had ever kind of committed to one of the explanations. And then there was what I like to call the holy grail. So it's called the EROS study, the Endocrine and Metabolic Responses on Overtraining study, which really was very nice and helpful for making this talk a little bit different from the talk from last year, because this is brand new and has really shifted everything about the idea of overtraining. So the EROS study was broken up into 3 study groups: athletes who were elite athletes who fit into overtraining syndrome. So they basically had these patients, they diagnosed them with overtraining syndrome based on the available criteria from the 2013 consensus statement in terms of our best diagnostic clinical diagnosis. We compared them to athletes at high level who fit a certain number of criteria as well. And then lastly, compared to a completely sedentary population control. And these people were not active within the last 4 years to the point of not meeting the criteria for the exercise guidelines. And this was a study done predominantly out of Brazil. So 4 research arms, they produced 4 separate papers out of this. There was a research arm evaluating the hypothalamic axis, the HPA axis, the basal sort of metabolic basal level axis, which we'll talk more about. So it was kind of just the name of the study. The profile in terms of mood, in terms of psychological things, and then the actual epidemiological data of the participants with it, compared to the stress or the psychiatric psychological approach to this study. So those are the 4 arms combined together. They had 1 summary paper. If you're looking for sort of 1 resource, that's in my resource at the end as well. But basically 4 separate papers were all published from this. A total of 51 participants, which absolutely in the grand scheme of sort of high quality evidence is not that impressive, but in the area of overtraining syndrome, this is groundbreaking in terms of magnitude and power by comparison. Last year in my talk, the only other study that was prospective that showed sort of actual randomized patients or anything like that was a total participation group of 9. So big improvement. At least this is the most data we've ever come across in the overtraining syndrome. Hopefully it's just the start in terms of better understanding of the complex condition. So in terms of the basal study, looking at the metabolic markers, the overtraining syndrome population compared to the athletes as well as the sedentary population showed altered white blood cell counts, specifically increased lymphocytes and decreased neutrophils, which biochemically we know has an immunocompromised sort of factor to it, and that's very common in patients with immunocompromised conditions. So that's one thing that is a proposed mechanism. We know that creatine kinase was one thing very classically looked for in overtraining syndrome and monitoring sort of muscle damage, et cetera. And this was sort of the best evidence that there is indeed a higher level of creatine kinase in these groups, which again, I mentioned before, could be indicative of oxidative stress to the muscles, causing greater inflammatory markers, causing greater damage to muscle tissue. Lactate was interesting because not only do we have an increased basal level of lactate in the muscle, which we know from previous sort of muscle physiology data does impair exercise tolerance. There's a delayed clearance in terms of short and longer term clearance in these athletes compared to the other populations. And in terms of the other things that were previously proposed as possible monitoring options for overtraining syndrome, ferritin, ESR, and CRP, no evidence of anything being in relation to those in terms of fitting the clinical diagnosis of overtraining syndrome. So something that was definitely believed to be involved doesn't seem to be as useful as we once thought. Now, moving on, overtraining syndrome resulted in decreased levels of testosterone in the blood, as well as increased levels of estrogen, believed to be secondary to the aromatase enzyme mechanism, basically increased adipose conversion of testosterone into estrogen. Largely, in a nutshell, creating an anti-anabolic state. We know that testosterone is an incredible anabolic agent, both endogenous and exogenous. If we have decreased testosterone and a decreased testosterone to estradiol ratio, we're going to get a decrease in adaptation, muscle adaptation, improved performance. very interestingly, across 117 biomarkers, they found that overtrained athletes were more similar to the sedentary population in many different markers versus the athlete population. So, an overtrained athlete is more similar to a patient who is not doing any activity than a patient who's doing slightly less and is not overtrained. And this is interesting, and it's sort of a bit of a philosophical change in terms of the approach to overtraining, because now there's a possible suggestion that overtraining leads to an actual loss of training adaptation rather than inhibited training adaptation. So what that will kind of touch on a little bit later is there has been the proposal by this group who did the ERO study of actually changing the name of overtraining syndrome to more reflect that it's a loss of training adaptation rather than inhibition of training adaptation. So that's something we'll talk a little bit more about. Now, the new pathophysiology of overtraining syndrome, and again, I just threw this up here mostly for the sake of anyone who wants to refer back to it, because you'll have a copy of my slides. It's obviously a complex condition. There's no way we're going to cover all of this, and truthfully, I would be lying if I said I completely understood this flowchart. But it's important to understand that we know there are multiple factors going into the diagnosis of the pathophysiology of overtraining. Some of the ones we mentioned: low protein intake, low carbohydrate intake, chronic energy depletion, excessive training, poor sleep habits, and add in the emotional, physiological, sort of cognitive stress of everything, the university, breakups, the team stressors, team dynamics, loss in the family, all can lead to sort of be things that will lead to the development of this condition. Again, from a physiological standpoint, multiple mechanisms at play in terms of where the actual physiological changes are happening. Energy storage, energy usage, inflammatory markers, leading to combined immunodeficiency. Therefore, we're not getting the adapted training response that we should get, especially in these elite athletes at some of the most vital parts of their career. Now, right down at the bottom, I didn't want to point out too much because I don't really want to get in sort of the controversy around changing the name of it, because they've now recommended we change the name of overtraining syndrome to paradoxical deconditioning syndrome. Again, I think, and some of the criticism of that in terms of other papers that have reviewed this is, we are trying to simplify the understanding of overtraining syndrome, and how is adding a new name and a brand new idea in terms of what we're naming it and changing the philosophical approach to it, how is that making it more easy to understand the diagnosis? It's sort of like how, our approach to sports hernia has come across over 30 different names. So sometimes it can be kind of counterintuitive and counterproductive, but they have proposed that name change, but it hasn't been fully adopted yet, but we'll see in the future. So moving on in terms of the actual diagnosis and what we're going to be looking for in clinical sort of settings, there is sort of the historical diagnosis of exclusion of overtraining syndrome. Previously, it was sort of a clinical diagnosis showing decreased performance, mood changes, lack of other causes of underperformance. Again, screening blood work, screening medical exam, those kind of things are going to help us diagnose those. And then the symptoms we'd be looking for would be sort of the fatigue, depression. Some previous evidence showed a possible role of bradycardia or altered heart rates at rest or versus during performance. But again, very inconsistent data, nothing really that important yet. Bradycardia predominantly at rest, tachycardia occurring during exercise. And again, so these are the type of symptoms you could be looking for in terms of these patients. Now, risk factors is an interesting thing to kind of consider. And this is, again, also from the ERO study, because they were able to retrospectively compare sort of that profile of the different athletes who are presenting with it to retrospectively identify some of the risk factors. So classic ones: excess training, excess increase in training volume, like our athlete before who switched from outdoor to indoor season. Obviously unrefreshing sleep is an important one. Huge shift in the last 10 years of our understanding of the importance of sleep, so there's no surprise there. Carbohydrate intake, protein intake, and caloric intake makes sense. We're underfueling the body. We're going to get a decreased energy available for sport performance. Work study ratio increasing in terms of adding that that mental and cognitive load as well, which is also a risk factor for this. And so they kind of identify these as, the main things we're going to be looking at decreasing or preventing in terms of risk factor prevention to obviously decrease the risk to our athletes. Now, this is sort of a slide about the classic kind of diagnosis of exclusion of the overtraining syndrome. But again, ERO's study has kind of taken a spin on that and tried to make it a little bit more clear cut. And once again, not something we're going to be able to cover all of it today, but something that's in there for the future. But this is their diagnosis conclusion of the study. So this is another paper they published based on the data that they found. They then tried to elucidate a better diagnostic tool. So this is the first step in terms of the diagnostic approach that they propose, which is the EROS clinical tool. Now, this is a combination of some of the things we've talked about in terms of risk factors, adding in the POMS, or profile of mood states, which I'm sure Dr. Edwards will touch on, or I'll cover in a couple slides as well, which is basically a screen for mental and cognitive performance, mental and cognitive fatigue in many different facets. And this kind of spits out a number in terms of a possible screening tool or clinical tool to help with the diagnosis of overtraining syndrome based on point percentage. So it's something that we did not have previously that would be, very concrete, very objective in terms of diagnosing these overtraining syndrome athletes. Now, based on that, they've also developed the simplified diagnostic tool, which is a little bit more in depth. So this is for people who kind of fit that mid-range of the diagnostic criteria. And this is to take it up another step or level, which is actually including basal levels of androgen hormones as well as sex hormones, which will help the diagnosis from a biochemical standpoint in these kind of wishy-washy cases. So something to consider if you're still not sure if the athlete is fitting the full diagnosis of overtraining syndrome, you take it a step further and then include the diagnostic data. Now, we're going to go even one step further, which is the EROS complete tool, which is they did identify as it probably overwhelming in terms of biological data and biochemical markers and the actual testing we're going to be able to do in a clinical setting. So it was proposed predominantly as a research tool as sort of the gold standard in diagnosing OTS based on all of the available sort of facets that they were able to study in this particular research intervention. So that's something that's probably out of the realm of really anything we can all accomplish clinically. Now that falls into this big flow chart, which is basically saying, do we have an athlete who we suspect of having OTS? If we do, we start with the OTS clinical tool. If they fit the diagnosis based on the clinical tool, bang, you have your answer of the OTS diagnosis. Or if they don't, there you go. If it's inconclusive or the performance is continuing to decline, they also recommended, based on that, you could move on to the EROS simplified score, which is, again, going to either help exclude or diagnose OTS. And then they also did include the sort of complete tool in the flow chart. However, they did note that it's probably beyond the realm of capability of the average participant and the average sort of medical practitioner. So it is there for in terms of that gold standard role, but this is the first diagnostic tool, diagnostic criteria, screening tool that we have ever developed for overtraining syndrome and has been studied pretty thoroughly based on the data that they've done. So all of that in terms of diagnosis and everything is sort of quite complicated. We've covered a lot, and then comes the treatment. So truthfully, the essence of the treatment is not surprising in that it's rest. In terms of overreaching, we rest athletes for 2 weeks and they will recover performance. So that is very easy in terms of if you have an athlete, you don't have these availabilities to these biochemical data, not everyone has the resources that Team Canada does. You rest them for 2 weeks. If the performance comes back, boom, you have a diagnosis of overreaching syndrome, either functional or non-functional, depending on how quickly that comes back. If they do not recover and they continue to have a performance inhibition for a prolonged period of time, then you can theoretically have a diagnosis of overtraining syndrome, and then that might be the time you choose to go into a further investigation. Now, in terms of actual monitoring for OTS, now this is something that the EROS study was not sort of able to touch on too much because it wasn't prospective, but it's something that they proposed things to help with. So as of 2018, 2019, no consensus, but hopefully it is coming a little bit further with that being one of the future directions of the EROS study. So how do we monitor these athletes now and today? Performance measures in terms of their exercise capacity, their VO2 max, their timing, their power production. there is this possible role of heart rate variability monitoring. Again, the proposed changes are going to be bradycardia at rest, tachycardia while they're exercising, which makes sense as we're not having the same exercise performance. So then we're getting a decrease in terms of the performance based on those muscles. So we're getting an increase in terms of heart rate load and need from that muscles, that system to produce performance. Peak muscle lactate, again, possible role, once again, inconsistent data. That's not something that was able to be studied in terms of monitoring from the ERO study, as it was predominantly retrospective with a component of it being prospective. POMS is something that we do with Team Canada, which is looking at sort of the different cognitive and mental fatigue aspects, which are tension, depression, anger, fatigue, confusion, vigor. This is something you can check daily, something you can check once a week, once a month, in terms of just monitoring athletes for that mental fatigue side of things. Again, previously, no obvious diagnostic cutoffs in terms of monitoring from the monitoring standpoint. So you won't know just based off heart rate variability or peak muscle lactate, but then you might be able to identify these as people who need to be further investigated for OTS, which might be a little bit easier than checking in and doing biochemical markers on every single athlete on your team. However, again, the ERO study coming in handy, basically developing these risk factors or preclinical alterations that might change or might happen in terms of biochemical markers, which could be indicative of upcoming overtraining syndrome. So things that have been proposed are the reduced testosterone, like we talked about, reduced BMR, basic metabolic rate, increased fat mass, as there is sort of a paradoxical increase in fat mass in these overtrained athletes, reduced muscle mass, and then again, we're kind of looking at some of the clinical surveillance type stuff like decreasing POMS, decreasing mood states, and those kind of things. So obviously, the most important thing with the overtraining athletes is going to be prevention. So now that we've identified way more risk factors than we ever knew about, as well as biochemical things that could be involved in monitoring, as well as the diagnosis, we have a better idea of how to approach prevention. So prevention, obviously greater than treatment, because we can do an active prevention while continuing to train athletes without having to make them completely rest, which is one of the mainstays of treatment. So training modification, performance tracking, huge. Avoiding repetitive training has been shown to decrease that sort of cognitive or mental fatigue in athletes. So again, altering your training based on part of the season and training loads and different sort of stimuli. Individualized training that fits the athlete's sort of specific goals, specific needs, specific performance, detriments. And then looking at one passive rest day per week. And the important thing with the passive rest day is it's also important to include the fact that mental fatigue is a major part of that. So if we have one of our cyclists for Team Canada who is training 6 days a week and they have one day off, and the only thing that they have time to do that day is get caught up on work from university or from school, that's not exactly going to be a functional form of rest that's going to be helpful for this athlete. So again, you need to kind of find something in terms of a passive way to keep them engaged and cognitively in a good space without, again, adding to that overtraining syndrome picture. From a nutritional standpoint, this is where team dietitians come massively in handy, as well as sort of the team therapists who can check in with daily rates, regularly reassess these athletes, making sure they're keeping up with the diet. Because there's a very interesting sort of trend for these athletes who are becoming overtrained, becoming mentally fatigued, their ability to keep up with meal prep and their ability to keep up with their dietary sort of recommendations tends to suffer as well. And that makes sense with kind of the whole clinical picture. Sleep optimization, huge. As we know, that's a whole conference in and of itself in terms of sleep and improving performance in athletes. Then that early recognition sign, so whether or not that's coming from that sort of performance tracking, or if it's coming from POMS, or if it's coming from daily weights. Again, the earlier we see these changes, the better. Treatment, it's amazing, in terms of the treatment, it really comes down to rest and then optimizing those things that we know that they're going to need to getting back. So we have treatment that needs to be dedicated at rest, as well as looking at dietary modification, evaluating everything that's currently going into the athlete's profile and training regimen to better assess when they get back how to prevent this from happening again, because as I talked about, massive risk of relapse. And then close monitoring, especially beforehand in terms of prevention as well as after, because these people can slip very quickly back into overtraining syndrome. It's not something that happens, another 6 years down the line. It's going to be something that's probably going to recur pretty quickly. So again, EROS came up with active prevention of overtraining in terms of reduced training intensity and volume, specific to the athlete, additional resting, affecting diets, managing sleep, no surprises in terms of what they recommend in prevention. One thing I will talk about is the idea of absolute versus relative rest. There is certainly data that shows absolute rest in highly competitive athletes and major endurance athletes. If we just absolutely rest them, there's going to be an exacerbation of some mood, some sort of stressors, because one, they're no longer training for the competition, they're no longer part of the team. So it's important to look at relative rest. Now we can greatly decrease their overall energy expenditure and performance sort of necessary for their regular training to decrease them to the point that they can recover with a relative rest period. But again, that's going to be very athlete specific and depend on the severity of the presentation of whether it be non-functional, overreaching, or overtraining. So important to consider that in some athletes, that maybe the idea of absolute rest, removing them from the team, removing them from all forms of training, might not be the best for that athlete specifically. So in conclusion, talking about athlete number one from Team Canada, in terms of triggers that he was dealing with, was that change from outdoor to indoor season. We actually then optimized his dietary requirements, increasing his protein, as there was a massive need for power optimization during that indoor training season. His chronically low ferritin, another trigger that we know he's always going to be a little bit more at risk in terms of having a baseline medical issue. Even though ferritin may not be exactly a marker of overtraining syndrome, it might be something that is sort of in his picture that might be related. So we kept an eye on that, made sure he continued on his doses. Couple family life stressors, the more deeply we got into it, there were a number of team stressors that year in terms of overhauling kind of the medical staff, not the medical staff, the training staff, as well as the preparation for the World Championships. So it ended up coming out in the fray a little bit. There was more tension in his life that we were aware of at the early stages. And then in terms of moving forward with monitoring, POMs were trending downward. So that was one of the things that did help our diagnosis. And then the fatigue 3/4 of the way through the efforts is a common thing that you'll see in these athletes. So to consider, but again, that depends on the sport that they're doing. So we rested him for 4 weeks. Part of the reason why we did for 4 weeks is because he needed to get a little bit of time away from the team. And the other thing was, this wasn't his first episode of overtraining syndrome. So again, we were a little bit more adherent to the 4-week kind of absolute rest. He was still involved with team activity, with meetings and those kind of things. We increased the frequency of his profile of mood states as well for monitoring. Obviously had the dietitian involved, and then a slow taper to return, which makes sense for these athletes rather than having to go right back to a full training regimen. He did then compete in the World Championships that season, and did definitely perform pretty well for his standards. So that was overall pretty good. But it was an interesting case, especially for my time as a fellow, and getting kind of see it from beginning to end was a lot of fun. So take-home points. Approach to the Tired Cyclist, massively broad differential with multiple factors at play, multiple things we need to consider. So always keep an open mind. Always think of the medical things first. Now that we have the diagnostic tools, it might be kind of helping change our approach to everything. Again, overtraining syndrome is an incredibly complex diagnosis. Hopefully the EROS system does help improve the ability to approach that diagnosis and make a more clear-cut, less wishy-washy diagnosis. Etiology, multifactorial, multiple factors at play from biopsychosocial standpoint. Prevention is key. Approach to management, rest, identification of triggers, management of triggers, dietary management, sleep optimization, obviously rest again, because it can't be said enough, and then slow taper to return to training. Obviously, we'll cover any questions. Hopefully I can help answer them. All the resources are in the last slide, and I'll happy to share my slides with Helen or Don so they get to everyone if you guys want to keep a copy of them.
Thanks, Scott. That was great. This is always a very challenging topic, and particularly as you worked with myself as well. We've had a number of athletes trying to go through this diagnosis with them. There's a couple of questions filtering through. If anyone wants to add any questions to the Q&A, we've got a few minutes. We are running a little bit behind, but if you have some questions, add them to the Q&A and we'll get to them. I had a quick question to start off. In your research, did you notice any difference in the incidence of overtraining in endurance versus power sports?
Good thought. So the ERO study did use a combination of both, which is sort of the first combination study, which was actually interesting. Predominantly, research to date had been almost exclusively aerobic, unless anyone has come across anything different with the rowers and the cyclists and the runners that I mentioned. Nothing in terms of, elite powerlifters, CrossFit, sort of American football, those type of things. Nothing in terms of those kind of more power sports that I've come across yet. Would be interesting that now we have sort of that diagnostic criteria. We might be able to approach it a little bit differently, but I have not. I'd be curious to know if anyone else has.
Okay, we've got a few questions. We'll try and get to most of them. First one was, when is the optimal time to do blood work to detect overtraining syndrome?
So that's interesting. And part of the thing is, and that's one of the things we came across with Team Canada was every athlete wants to know their blood levels at every single moment of every single day. And, those who deal with university athletes and university runners, there are many, many athletes who are really quite obsessed with monitoring the blood work and following it, especially from an aerobic sort of endurance athlete standpoint. I think it's hard. And again, that wasn't necessarily a true recommendation that's come out yet. And the other thing is, do we approach every athlete who's new to the team by doing a full sex hormone panel and testosterone panel to know their relative levels and then to monitor for change there? That's a possibility. Again, I think one reasonable approach would be that sort of new diagnostic approach, which would be do the initial ERO screening clinical tool. If that's giving you that diagnosis, then boom, you might not even need to bother with that complex set of blood work. Because again, not everyone has the ability to do that level of blood work at a high frequency or immediately, like some of our elite national teams do. And then if that doesn't fit that clinical screening tool, then you move on to the next one, which is that simplified EROS tool, which is the one with the more detailed sort of biomarkers. What is interesting is how they did compare the numbers, to the sedentary population, and it did show a significant difference in those markers that are mentioned. So what helps is that you don't necessarily need a baseline because it's not a relative change to their baseline. Instead, it's actually just a flat number. Is their testosterone below this? Is their testosterone estradiol level this? So that might help us with not having to overwhelm sort of our athletes or our labs with complex sets of blood work that, when you're looking at the cost effectiveness of this, and especially not all elite athletes, really you're kind of trying to find if there is a good clinical role. So I think at least that would be my approach now, would be using these new clinical diagnostic tools. It does need to be replicated. It does need to be done by another center. And hopefully, somebody can confirm that these diagnostic tools indeed are consistently effective. Also, major limitation, which I should have mentioned before, the ERO study only was on male athletes. So interestingly, the two largest studies prior to that I was able to find, the one with 9 and another one that was a little bit further with retrospective, was predominantly female athletes. So again, that is something that the EROS group has identified as their next step, is actually replicating the findings in female athletes. So again, early stages, but we'll see.
Okay, I'm going to combine a couple of questions here because they're somewhat similar, and then maybe one question after that. So more has to do with sleep. So two kind of related questions from Charlotte Alabaster and Michael Clarefield. What's the definition of 2 weeks of rest? How much sleep, hours of sleep, etc.? And Michael Clarefield's question is, what do you use for sleep optimization?
Well, I mean, from my standpoint, I think everyone could probably learn more about sleep optimization. I don't want to get into that because I don't even want to pretend like I know, more than the basis of sleep optimization in terms of, the classic 8 to 10 hours, looking at how you're, traveling across the world and looking at travel in terms of your sleep and how that's going to impact it. I think that that's also going to vary greatly in terms of the athlete you're dealing with, what type of sport, whether it's adding naps because of the training schedule and their travel schedule, or if it's sort of sleep optimization in terms of looking at completely overhauling their sleep cycle, whether they're sleeping too much, too little. For the sleep optimization thing, I think I'll leave that for another talk or another day. I don't think that's something I want to get too much into today. So that would be a good topic for next year potentially, or, Chasm often will cover that. And Wade, what was the other thought there? The other question you had?
I'm just going to go to one more. There's about 5 questions, so maybe afterwards, if you want it, you can actually type some answers to some of them in the Q&A, but I'll do one more and then we'll move on to the next topic. So the next question was, thank you, that was excellent, from Carl Shearer. You have mentioned that prevention is the key, understandable. However, I foresee great difficulty getting coaches to buy into training modifications. Do you have any comments?
I mean, it's like anything. It depends on the team setup. It definitely was a problem with part of the Team Canada culture earlier on. But it's going to vary greatly. And I think, we're also changing in terms of our understanding of high performance in sport, and how, the sports science team does have a massive, role to play. I think we've all heard the term load management way too many times in the last few years, but that's something that we are starting to understand a little bit better in terms of, if we can monitor for declining performance in these athletes, we can bring it to the coach and say, this is why we need to decrease the amount of training load, because they are getting overwhelmed. And so major issues with kind of the culture of the team and the communication between the medical staff and the team is going to be huge at play there. Obviously, having more brains sort of thinking the same way, whether it's a sport lead or a sports psychologist or, just the athletic training staff, all are going to have to kind of make sure the voice is heard. And again, going to be massively dependent on your setting and your team. It's something that our OHL team is doing a hell of a lot better at than, even we were 3 years ago when I was a resident working with the team. So small changes over periods of time that hopefully continue to move us in the right direction in terms of improving sport performance, and the combination of sort of sports science and performance, I think, it's definitely something worthy of a major topic moving forward.
Okay, thank you, Scott. That was a fantastic talk. I will leave the questions there if you do want to respond to some of them.
Cool. Yep.
Moving on to our next talk, and our last talk of the evening, we are very pleased to have Carla Edwards here. Many of you will know Carla as a sports psychiatrist. She works with a few of the national programs, and I've been fortunate enough to work with her both clinically as well as with Team Canada Cycling for a few years now, and we've shared many patients in her realm and mine as well. Getting back to the theme of traumatic injuries, and Carla is doing a talk later in the series as well, but tonight's is going to be focused on things we don't always think about when we're dealing with traumatic injuries, is the after effects for that, and more the psychological side of traumatic injuries. So I will flip things over to Carla.
Thanks very much, Wade. Hi, everybody. I'm very happy to be here talking to you. Hopefully you can see my slides okay. I'm acutely aware of the time, so I'm going to keep my eyes on that and try not to keep you too late. I also want to apologize for the poor lighting. This is literally the first Zoom meeting I've had at night in my basement office, so I'm acutely aware of that, and I will try to fix that up for the next time as well. Also a disclaimer, one of my kids may come down looking for me soon because it's getting right around their bedtime, so if someone peeks through that door, I'll try to put them off a little bit. This is a tough topic to finish the night on. It's a tough topic anyway. Andre started us off with talking about different types of trauma in cycling. The type of trauma that I'm going to be talking about is a bit more, from a psychological point of view for sure. A lot of it does overlap with the traumas that cyclists can experience from a physical point of view, but certainly mine will be trending more towards the emotional side of things. I do not have any conflicts of interest to declare. This is kind of an overview of what I'm going to talk about in the next little while. There's different types of traumatic events in cycling. We're going to look at crashes. I'm not going to show you any graphic videos because that's been covered. I was saying to Helen earlier, I wish we had videos on people's reactions as they were watching some of those videos, because I know I was aghast at some of those the visuals. We have catastrophic injuries in cycling. As we know, we have some deaths directly and not directly related to cycling itself. But really what I want to focus on is the community impact. We know those of us who treat athletes, which would be pretty much everybody on this call, know that sport exists in small communities, even though it's a global entity. And we can become acutely aware of what can affect each of those communities more so than others. And hopefully by the end, you'll walk away from this with an approach to know how to kind of delve a little bit more deeply into some of the psychological traumas that some of our athletes may have when they experience some of the physical traumas. Images that are disturbing are nothing new to most of us here, and certainly my images are not going to be anything close to what Andre's were. The first topic that I'm going to talk about are crashes and some of the psychological impact from those crashes. We've seen the videos and some of the pictures. This is the Australian women's track endurance team. About a week before Rio 2016, they were doing a final training prep before they headed over to Brazil. And at speed, they rubbed wheels, and everybody went down except the lead cyclist. So one of their cyclists was carted off on a stretcher, but was able to leave the hospital within 6 hours and was able to compete the following week in Rio, thankfully. This gentleman is Phil Gaiman. He was a professional road cyclist and decided in his retirement from professional road cycling to have a crack at track cycling, and went to Trexlertown, Pennsylvania, and had a pretty dynamic crash on the concrete track there, and as a result sustained a number of rib fractures, clavicle fracture, scapular fracture, and was really unhappy. But he documented all of this in his YouTube series, The Worst Retirement Ever. He did not have a good time in his track cycling career. And this story, Victoria Williamson-Barnes, I'm going to talk a little bit more deeply about hers. She had a pretty big crash a number of years ago, which impacted her life significantly. And I think if we were to sum everything up about cyclists, one thing we can say is they're definitely, they're tough individuals with what they go through. We've seen some images of road crashes as well. I'm not going to talk about all the different things you see here, but one of the things that I noticed yesterday as I was going through these again was you can see a bike kind of flying up in the air in the bottom right picture there. We saw on an earlier presentation, fisticuffs coming out as well. So cycling is definitely a tough sport, and let's not ever forget that. First, we're going to talk a little bit about catastrophic injuries and the impact that can have on people. This first story, I'm just going to tell a few stories to you about these people. So Victoria Williamson-Barnes was a Great Britain cyclist. She got a bronze at the 2013 Worlds with her team. And then in January of 2016, half a year before Rio, she was in a race in the Netherlands and locked handlebars with her competitor, sprint competitor, and she went down. And they initially didn't appreciate the extent of her injuries, but what they found was a significantly deep left flank laceration that went to the level of her spine. And when they turned her over, her partner could see her spine literally. And I mean, as physicians, we train for things like this, for images like this, but certainly other athletes aren't prepared for that, or coaches or other bystanders. So it can be quite traumatic for anybody who sees that kind of thing. So she was kind of put back together and brought to hospital in the Netherlands, and they had to do an initial stabilization of her pelvis. She had a fracture dislocation of her pelvis. They had to do some tissue repair and debridement. And then she really she was too unstable to be moved for any further procedures, until about a week later when she was able to go airlifted back to the UK, where she underwent further back surgeries. And she had extensive fractures. She had neck fractures. She had lumbar fractures. She had the pelvic fracture. She had obviously a brain injury, and they weren't initially sure if she was going to be paralyzed until she was able to be more conscious, and they were able to do more testing. There's the initial fixation of her pelvis, the stabilization, some of the closures of her wound. You can see the progression of her healing of her wound there. And when she was able to be more interactive, you can see her more responsive. But the progression of her experience through this crash was, her initial crash, which she had no memory of. All she could remember was lining up at the starting block, and then coming in and out of consciousness at the hospital sometime later. She underwent multiple surgical procedures over multiple weeks, and she was in that supine position, unable to move in the neck brace for a very long time. She wasn't able to attempt sitting up for about 3.5 weeks. And when they first tried to sit her up, she only lasted for about a minute until she lost consciousness. because of the amount of pain that she was in. It took her 4 weeks to be able to not be fed. And it took about 4.5 weeks before they could actually stand her up for a few seconds. So this is a young woman, early 20s, Olympic hopeful, whose life was certainly suddenly turned upside down, and she had to rebuild her body, and she had to rebuild her life again. This was an image of them just trying to sit her up, her just standing up for the first time after a month, and then just learning how to walk again. About 2.5 months later, she was able to do hydrotherapy and start doing some more movement in the pool. Throughout this entire time, she maintained her focus on returning to cycling. She couldn't wait to get back on the bike. She was checking in on everybody else to see how they were doing. I don't think she fully appreciated initially how dangerous her injuries were, but she was able to talk about it with some candor later. This is the hardware that was removed from her spine and pelvis about 5 months later. This woman was driven. You certainly can't take that away from her. Her goal was, she missed Rio, obviously. Her goal was Tokyo, but her more immediate goal was Commonwealth 2018. I checked the roster. She wasn't on the roster for Great Britain at that time. However, what I did learn was she did return to cycling quite successfully. She qualified for the 2019 World Championships. And after that decided to switch to bobsleigh. So she is now on the national team for bobsleigh for Great Britain, which is kind of interesting because in Canada, we actually see it the opposite way. A lot of our cyclists actually started off in other sports like bobsleigh or soccer and then become cyclists. So she switched over to a different sport and has found some success. The second story is Christina Vogel, who was known across the world in the cycling community, multiple, like 11-time world champion in sprint, multiple gold medalists at 2 different Olympic Games, and was, again, top of her sport until 2018. One of the videos we saw earlier was of a cyclist hitting a starting block and tumbling over head over heels in the air and landing. And this is what happened to Christina when she was training in the Netherlands and on a concrete track. And there was a young cyclist learning how to do standing starts in one of those starting blocks. And she came around the bend at speed and hit one of those. And she kind of dropped off the radar for a number of months. And so the accident happened in June 2018, but it wasn't until September when she really emerged from it and told her story about what happened. So she had a spinal fracture at T7 and was paralyzed and has been in a wheelchair ever since. She eventually made her way back to a velodrome and was sort of the host for one of the Berlin World Championships. But again, she was another one who had to go from top of her sport to rebuilding their lives. And I can't even begin to appreciate emotionally and psychologically all the different stages that they would have to go through. Sometimes these athletes are able to find or redirect their passion in another sport. With Christina, she took up archery. Hard to know if she'll ever compete on a world stage in archery, but she might, we don't know. But certainly that the fire that fuels them when they're able-bodied certainly doesn't get extinguished when there's an accident, and we sometimes need to help them manage that. We don't have to look very far from home to find our own stories. Kate O'Brien is one of our athletes who went to Rio. She was another sprint cyclist who had a training accident after Rio, actually, and had a significant brain injury. And over the subsequent 2 years, she had to rebuild her body. She had to learn how to walk again, how to talk again, how to feed herself. And throughout that entire time, she never lost her passion to get back on a bike. So last year, she returned to Milton and competed in our one of our World Cups there, or our nationals, and was able to get a medal. So she, again, continued to work hard and didn't allow this to keep her down. Stefan Ritter is another one of our sprint national team cyclists who had, he actually had 4 crashes in a 2-year period. He broke his clavicle and a number of other MSK injuries, as well as 2 head injuries. And his worst one was at the Pan Am Games in Mexico 2 years ago. And again, he, as you can see in these pictures, had to learn how to rebuild his life. So these crashes are not trivial. We talk about some of the more minor injuries that they can have that can be repaired, but for some of them that are a bit more catastrophic, it can have quite an impact on their lives and their recovery. Sometimes the catastrophic injuries have tragic outcomes, and there are some outcomes that are actually pretty final. This is Ellen Waters, who is, again, well known in our cycling community. All of these people know each other because they've cycled together, and the community is quite small. Ellen was from New Brunswick, and while she was training at home, one December was hit by a vehicle and passed away from her injuries. And I mean, when I first became involved with cycling, I heard her name quite frequently. Her death had a big impact on a lot of people. She was well known and well liked. And it's not just about what they do on the bike, but it's about the person that they are and what they bring to the sport. And I heard many, many stories about Ellen and how she would just stop on a training ride and just look at a waterfall, or literally pick up some flowers and smell them. And it drove people crazy because they just wanted to ride. But it's those things that actually made her a significant individual, and her passing had quite an impact on the cycling community. Stefan Loos was a young man, 19 years old, Belgian cyclist, just early in his pro career. And he was on a race one time, and the pack became separated, and the race directors misdirected a whole group of cyclists in the wrong direction. And they went through an intersection that wasn't cordoned off because they weren't supposed to go that way. So he and two of his teammates ended up colliding with this van, and unfortunately Stefan lost his life in that collision. So again, ripples in that community, ripples in the cycling community as a whole, for the loss of this young life. There have also been a number of deaths in cycling that aren't directly attributed to cycling itself in terms of an accident or a trauma, but nonetheless have as big an impact on the cyclists themselves. Kelly Catlin, again, well known in the cycling community, multiple world champion. She was an Olympic medalist for the USA cycling team. She was a pro road cyclist with rally cycling. She was a brilliant student. She was doing her PhD in computational math and mathematical engineering. She was an accomplished artist, a violinist, and she was driven. This person was very driven and just wanted success on all levels, and that eroded her over time, of course, as we can understand. In addition to this, she had a number of crashes and a number of head injuries, and some of those raised questions after her untimely death. So in March 2019, she was found to have committed suicide at her apartment at Stanford University. And it was after that on reflection, people started to really put pieces together and try to understand, how could this person who seemed to be, again, at the pinnacle of her career, so much success, so much brilliance, so much promise and potential, how could it end in this tragedy? But then they recognized she had struggled from depression in the past. She had had a suicide attempt previously. They had tried to connect her with supports, but her family just noticed that she changed significantly after she had a couple of crashes the fall and winter prior to her death. And her family just noticed a change in her that just never really recovered. Whether it's from the head injury that she had in the fall, or the interruption in training that she had as a result of the head injury, and the wrist fracture that she had. She had persistent post-concussion symptoms that also interfered with her training. She was part of a triplet, so her siblings made several comments in the press about how it would just make her so angry and unhappy to not be able to train because she just couldn't tolerate the exacerbation of symptoms when she was training. So because she wasn't able to maintain everything as she had before, it just became intolerable for her. Charlotte Creswick was a Canadian athlete, actually. She was a junior national champion. She was quite successful in the international junior scene as well, and was in her second year of university in Kitchener